We are way forward, Chair.
Okay, we're now live.
Okay, thank you very much. And good morning, everybody. Welcome to this meeting of the Health and Wellbeing Board. Excuse me. So could I start off with substitutes and apologies? Who's got those for me?
Yes, Chair. I've got apologies from Anna Basford, and I was told that Zoe Aitchison would sub in for her, but I can't see her on the screen as yet. I've also...
Zoe's a PA with a CCG. She won't be subbing for
Anna.
For Anna.
Is it Lisa that's subbing? Yeah.
Yeah,
So Lisa
I'm here for Anna.
Yeah.
Oh, sorry. So Lisa's subbing for Anna. Great, thank you. And then Karen Jackson is also sending a sub as Janet Garrett. Again, I've not seen that name come up yet. Apologies from Anna Basford, Karen Jackson, Deborah Harkins and Sue Lewis.
Hi Diane. Tim Fox is here for Karen Jackson.
Tim Fox, thank you.
Okay. And I'm not quite sure with paternity leave arrangements, but I guess it's simplest to record Councillor Courtney as substituting for Councillor Wilkinson, and apologies from Councillor Megan Swift.
Okay, thank you.
So item 2 is to remind members to declare, to declare any interests that don't otherwise arise. Item 3, there are no confidential items, so we don't need to exclude the press and public. Item 4, minutes of the meeting held on the 16th of December. Could I check first of all if there are any points of accuracy on those? Okay, so can we agree those as a correct record? And yes, that's agreed. Thank you. So, item 5, question time. I've forgotten about question time, but I've not been told of any questions. I take it we don't have any, Diane, no?
I've not had any questions submitted to me, Chair.
No, okay. Excellent. So item 6, reducing the reducing the impact of COVID, Calderdale Bay Action Plan. So Pam, are you leading off on this?
Lisa's going to kick off.
Lisa, okay, thank you.
Okay, thank you, Councillor Swift. Good morning, everyone. My name's Lisa Williams. I'm the Assistant Director of Transformation and Partnerships at CHFT. Firstly, can I convey Anna's sincere apologies for not being here this morning. She's unfortunately been called for jury service, so it was something that she couldn't step out of. Thank you for inviting us to give an update on the COVID-19 BAME Action Plan. I'm going to hand over to Pam now, who is going to summarise the work that we've done so far, and she's going to share a really interesting, really powerful video with you. So I'll hand over to Pam. Thank you.
Thanks, Lisa. So for anyone who doesn't know me, I'm Pam Bupow. I work for Calderdale Council and West Yorkshire ICS. And as Lisa's mentioned, I'm here to bring an update on the work that we've done on the BAME COVID Action Plan. So bizarrely, today marks 2 years since the pandemic. Well, as we in Calderdale we were really starting to feel it. So hopefully today you'll get a flavour of the amount of work that we, and I say we, collective as the council and partnerships, have done with our communities and created with our communities to protect them throughout the last 2 years of the pandemic. So if I take you back to the start, we had Kate Horn and others in public health had various conversations with residents, community groups, organisations about their thoughts, fears and worries about the pandemic. And some of the things that really struck out at me at that time was 3 things. Independent Asian shops were really skyrocketing their prices of food. So people were really struggling to buy stuff. Not really sure why that happened, but it was happening. One story was around an Eastern European lady with 3 children, and we asked her about what her thoughts and fears were around the pandemic. And she went, what pandemic? What what virus? And that was 6 weeks into lockdown. So we just thought, and that's because she didn't have a TV, she didn't have a smartphone, she just had no way of knowing. So that really struck us in terms of how we're going to be communicating our messages. And I guess the last one was, and I don't understand this because I was stranded in India at the time, but there was a lot of fear across South Asian communities about if anybody caught the virus, they were scared to go into hospital because the fear was they were never coming out again. So that still, even I heard about 2 months ago, that still remains. So taking in all of these conversations and the data that we had, we put together an action plan with 10 goals and a lead for each one of those. And I think it's important to say that Anna Basford's the chair, and we were quite keen that it was somebody not in the council, so that it didn't feel like it was a council-led plan, and it was very much partnership. So you'll see from the video that we're about to present the amount of work and the engagement that we've done, and we've been really keen to co-produce any activity and campaigns with communities, especially in Park and Whalley. Lots done with businesses and schools and with the first sector. So all of this has been in the context of we've been through quite a journey in the last 2 years of full lockdown, to Calderdale's been in the highest level of restrictions for the longest period, I think nationally. I think were we tier 3 or tier 5? I can't remember which one, but we were in them for the longest. To more full lockdowns, and obviously in that time new variants were coming to play too. So in all of that, the action plan has reflected all of those changes too. I don't want to say too much about the activity that we've done, but I think you'll be able to see that we've really been able to sustain and really strengthen a lot of relationships that weren't there pre-pandemic. So with the private hire and taxi companies, that wasn't great before, but we've really worked hard and sustained that relationship. We've really listened to what people have said to us, and we've acted accordingly, and vice versa. I'm just going to throw this story in. So as part of the action plan, we've got the West Yorkshire anti-racism movement, and that's the place that we want to create in Calderdale. So I have sent a West Yorkshire anti-racism pack and a badge to Samuel L. Jackson, in the hope that he's going to be donning one of our anti-racism badges. So we'll see if that happens. And probably lastly, just to say that you'll see from the papers that we've got nine goals, and if we're going in the right direction of creating resilient communities, addressing health inequalities, and creating COVID-aware communities, that trust and confidence in health and care services will come back again, because I think that was really undermined in the pandemic. And also just to say that this work doesn't sit alone, it sits with the anti-poverty strategy, involving people strategy in the CCG, and the economic recovery plan. So at that point, Fazana, if you're okay to play the video, fingers crossed. Fazana, I don't think there's any sound.
Right, let me try again. Sorry.
When the COVID-19 pandemic struck our local communities in 2020, it soon became clear that our Black, Asian and minority ethnic communities were being hit harder by the virus. This is a story of how our communities have worked together over the last 2 years to tackle the impacts of the pandemic. It was really important that we work together with our BAME communities to understand how we could best narrow the inequalities gap. We spoke to residents of Park Ward to hear about their real life experiences. These first-hand stories helped shape Calderdale's action plan to reduce the impact of COVID-19 on our BAME population. Goal 1. Early identification of COVID-19 in Calderdale's BAME communities. Identifying COVID-19 amongst BAME groups as early as possible was really important to help stop the virus spreading to other people in the community. A local test and trace system, which was staffed by people from the local community, was quickly established with help of faith leaders and local community groups. This made access to testing easier by offering vaccinations at mosques and other places with large congregations. One of our most successful sites, the Asda PCR testing centre, was created with active community involvement. Goal 2. Ensure that groups who are most impacted by COVID get the support they need. People told us that there were barriers to following self-isolation, social distancing, and shielding guidance. To help with this, we made sure that everyone got the help and support they needed by making our self-isolation grants more accessible and even easier to apply for. We also trained our fantastic contact tracers to give advice on all the support available. The community fridge was set up by local people in Park Ward to improve access to food.
At the start of the pandemic in 2020, we supported the Halifax community with food parcels. We were able to offer hundreds of food parcels in a short amount of time. However, there was a need for something more permanent in place, and we launched the Halifax Community Fridge. For the last 8 months, the community fridge has been serving the Halifax community. We average around 40 families visiting the fridge on a daily basis. We're open 7 days a week. We have people from every nationality, every background who visit the fridge and take benefit from the fridge.
Goal 3. Prevent COVID-19 in high-risk occupations and care homes. Talking and engaging with our local BAME communities helped us recognise the deep concerns they had about the higher risk faced by people working as care staff, private hire taxi drivers, and local independent shop workers. In response, we developed a Safer Spaces work programme which focused on preventing COVID-19 in workplaces which had regular contact with members of the public. This included transport with specific support for local taxi drivers.
Here in the centre of Halifax, they're asking these drivers if they sign up to routine tests to combat asymptomatic spread of the disease.
I don't know whether you'd be interested in it or not. It's something that we're offering all the drivers. We'll cross that bridge if it comes.
These drivers are already struggling financially. Their industry has collapsed. For many, having to self-isolate and lose what little income they're still bringing in could put them off routine testing.
And these taxi drivers, with the fear that if they are tested positive and they have to self-isolate, they simply will not be able to run their household.
Goal 4. BAME communities are aware of COVID risks and how they can protect themselves and their loved ones. People told us that they were confused about the social distancing rules and shielding and what they had to do to stay safe. So it was important that our messages were clear and accessible so that everyone was aware of the risks and knew how to protect themselves and their loved ones. When further lockdown restrictions came into force in Calderdale in September 2020, we worked closely with faith leaders to get our messages out there, enlisting COVID community champions and by running advertising campaigns using bikes and local community TV and radio stations.
As the chair of Calderdale Council of Mosques, I'm really pleased with the government decision to allow the mosques and other places of worship to open for community prayer. Communal prayer is such an important aspect, not only for Muslims, but for all religious organisations. And to be allowed to come back to the mosque for communal prayer allows us to provide that support and that help for people most in need.
As Director of Public Health for Calderdale, I want to thank the community for all your support over the last 8 months. I know how hard mosques have worked to put the right measures in place and to protect, support and comfort your communities during these unprecedented times.
Goal 5. Deliver programmes to address underlying health conditions associated with poorer outcomes from COVID-19. As we learned more about COVID-19, it became clear that a number of behaviours and long-term health conditions were linked with poorer outcomes. So, to tackle this, we delivered targeted campaigns to support healthy pregnancy, healthy weight, stopping smoking, and effective management of long-term conditions, including diabetes, hypertension, and heart disease. Goal 6. BAME communities are resilient as we learn to live with COVID. To build resilience as we learn to live with and recover from COVID, faith organisations played a critical role in providing support and advice around burials and funerals whilst under COVID restrictions. Our COVID champions were also enlisted from our local communities to help with engagement and messaging, as well as supporting lateral flow testing and pop-up vaccination clinics. Goal 7. A racially inclusive recovery from COVID-19 in Calderdale. We believe that Calderdale's inclusive approach to COVID-19 recovery will help reduce both the social and economic impact that causes inequalities in health and create long-term sustainable change for our BAME population. An inclusive economic recovery plan has been developed with reducing inequalities as one of its top 3 priorities and includes wealth building in Park Ward by encouraging entrepreneurs from within the community. Goal 8. Calderdale partners and communities understand the scale of inequalities experienced by BAME groups and are taking action to address them. Our communities told us that they were concerned to hear that we didn't have robust data on the impact of COVID on BAME groups when ethnic monitoring has been in place for so long. This prompted some focused work using health inequalities data to complement clinical prioritisation so we could reduce the risk of treatment delays and help address the widening health inequalities within our communities. This included understanding and taking actions to reduce inequalities in waiting times caused by deprivation, mental health conditions, learning disabilities, and for Black, Asian and minority ethnic communities. Goal 9. BAME communities in Calderdale have confidence and trust in local public services. It is clear to us that the root cause of the disproportionate impact of COVID on Calderdale's BAME communities is the long-standing structural inequalities and societal discrimination. We know that we must all continue to play our part in challenging racism and other forms of discrimination in order to tackle the root causes of health inequalities. This action plan was forged by listening and learning from people's lived experiences. Partners have signed up to an anti-racism pledge and health inequalities have been given priority in all our recovery plans. A call to action. We may be entering a period where COVID is not as widespread in our communities and life can return to some kind of normality. However, our work won't stop here. It's vital that we continue to strive to narrow the inequality gap and our action plan remains relevant and focused. At the start of the pandemic, our BAME communities told us that they were afraid of visiting health and care services in case they contracted COVID-19. As the pandemic has progressed, there was also frustration at the mixed messaging coming from those in authority. We will only know that our actions have been successful when our BAME communities tell us that we have rebuilt their confidence and trust in local public services.
Thanks, Fazana. If you could take down the video, please. Thank you. We also felt this morning that it was really important for you to hear a community voice. So we've invited along Nadine Meir, who is the chair of the Council of Mosques for Calderdale. So if I could invite Nadine now to speak, please.
Good morning, everybody. Thank you for the opportunity to talk to you this morning. You've seen a lot of work that's taken place in relation to addressing COVID, the threat of COVID, in particular with BAME communities. I just wanted to say a few things. I think a lot of the success really was around the partnership working. It was that really effective engagement that grassroots organisations had with both the local authority, the CCG, in trying to understand what the issue was. And one of my highlights really was the weekly meetings, the places of worship meeting that we established very, very early on with Deb Harkins. And what that did was allowed us to share information in real time to try and understand the extent of the issues. Certainly with the Muslim community, congregational prayer is a very, very important facet of their daily life. And then to be asked not to attend a mosque was very, very much alien. There was a lot of messaging, key messaging that had to be produced and developed. But in line with that, it was the training that had to go to the mosque committees and the trustees to get them to really understand the impact COVID was having and why the restrictions were being put in place. So it wasn't only trying to address, concerns from a community, but also then the misinformation that was being spread via social media, lots of other platforms in terms of conspiracy theories, that if you did this, this is what would happen. A lot of the time, our female members of the community were left isolated because the mosques were predominantly male orientated. So Calderdale Council of Mosques had to develop a programme whereby we could get the women back into the mosques, get that key messaging out to them, because they were the ones in the main that were nurturing a lot of our young people. And it was young people that we were also trying to target to ensure that everybody stayed safe and we covered everybody. So the training was really, really key. The sharing of that intelligence is what really shaped the model and the programme that we put together in Calderdale. Because what that allowed us to do was share real-time data and information with the community that in a lot of occasions sort of dispelled that myth that actually COVID is here and it's very, very real. And in particular with funerals, if you've ever had to attend a Muslim funeral, looking from the outside, they look very, very chaotic. Because lots and lots of people attend, everybody wants to be there, it's part of a religious commitment, but looks very, very disorganized. And again, the messaging that we had to do there was not just messaging, but actually enforcement. So community safety, the wardens, using Sale Suleiman, actually physically having to be at the cemeteries to control the numbers was a large part of the work that we had to do. And that can be very confrontational. So again, trying to train up volunteers in terms of how to deal with that confrontation when people are trying to attend the funeral of a loved one or a family member and being told, actually, it can only be 10, 15, no more than that, was very, very challenging. And I think really the Council of Mosques were able to gain that trust and confidence. And that's a word that we've heard quite regularly in terms of gaining that trust, getting the confidence of the BAME community so that they can understand and feel part of what we're trying to achieve. So buy-in for me was a big key. The messaging that went out, the people that were giving that messaging had to be credible. Calderdale Council of Mosques has obviously started to build up that credibility, not just with the community, but with key members and also with our partners. And really that's been the success. And I think we can't just rest on our laurels at this moment in time. My personal view is there's still a lot of work that we have to do. We're coming into that recovery programme. There's a lot of work we're going to work on in terms of, again, building that resilience into communities. So again, they don't feel as though any treatment or any programme that we as a group decide to put together do not feel as though that they've treated any less equal than their counterparts. So there's some work that we need to do with that, and I'm quite happy to help and continue with that work. So if there's any questions, I'm happy to answer them.
Thank you, Nadine. As you can see, there's been a huge amount of work that's been undertaken as part of this action plan, and we've hopefully conveyed some of that across to you today and summarised that. I'm very conscious that Anna's not here and that Debs isn't here, so we would be happy to take any questions, anything that we can't answer. We would gladly get an answer to you as soon as we can, once we can get in touch with Debs and Anna. So happy to take any questions.
Thank you so much, Lisa, and Lisa and Pam and Nadeem. And there's some very positive comments already in the chat as well. Are there any questions or comments? Yes, Ashley, Councillor Evans.
Thank you, Chair. Clearly a huge amount of good work has been carried out, and so thanks to all the people that have been involved and continue to be involved, and for your report this morning. I think it was related to, and particularly in the last contribution, there was a reference to the need for ongoing work in the BAME community in relation to these defined objectives, and one hopes that this will continue at the rate and level to which this has been done. So I think very, very good work being done. Clearly it will need to carry on. One other aspect I think is worth referencing is that there was regular reference in the reports to Park Ward. I think it's important to remember that the adjoining Whalley Ward has a large and increasing BAME community. And I know we've got a couple of organisations which are Park and Whalley, but I think, and okay, perhaps I'm being a little parochial here, but I think it's important that we recognise that there is a significant and growing BAME community within Whalley Ward also who need this help and support, which has been very good so far. So thank you for that. Thank you.
Thanks, Ashley. And I just Pam acknowledging that point about Whalley Ward. Ian.
I think I'd just like to say thank you for bringing such a vibrant presentation to the action plan. I think it's really timely, and I think Pam started off by talking about kind of we're at that kind of 2-year anniversary, and I don't think anybody 2 years ago thought we would still be learning to live with COVID in the way that we were having to. I think the action plan is really good, and I think it's a real testament to the work of everyone that's contributed and influenced that. I think also what's going to be really helpful moving forward is how our learning from doing this piece of work can truly be embedded in the way that we listen to, engage and co-produce with communities, work beyond COVID. And I think what I would hope we do is bring forward the real strengths of what we've learned by true community participation and build that into the way that we do normal business. So through adversity, I think we've learned a new way of working, and I hope we take that into the future. So that's really helpful. Thank you to everybody.
Sorry, excuse me. Thank you, Ian. Stephen, Councillor Baines.
Yes, thank you, Tim. I agree with everything which has been said, and especially what Ian, who's no relation of me, by the way, said. It's part of the things that I covered as well. But one thing that I recall at the beginning, one of the biggest problems in the community was actually getting them to vaccinate, and that it was in their best interest to vaccinate. And I just wonder how successful. I know you did do a lot of effort to try and convince people that it's the right thing to do, but how successful was that? Because it's I think that's a major thing with any sort of medicine. If you don't listen to the doctor's advice and follow it, you're a bit of a fool, in my opinion. But so could somebody sort of set any information on that? Thank you.
Well, if I can just quickly say something, because I think vaccination was a massive issue, certainly within the Muslim community, because initially some of the messages that were going out was that it wasn't halal. that you weren't allowed as a Muslim to take that vaccination. And we very, very quickly jumped on that by getting testimonies from doctors, from the medical profession, to reassure communities that it was something that was permissible, it could be taken, and there was no religious barrier to taking that. And as soon as that message went out, we saw a slight increase. The other time we saw an increase was when the misinformation was very, very quickly taken down and the counter narrative was put in place. But like any community, what tends to happen is you will get a small cohort that no matter what pressure, what information you give to them, they have made their mind up that they are not going to take that vaccination. So our second approach was actually, as I mentioned earlier, was the young people, to educate young people, to maybe put sort of an indirect pressure on their parents in terms of, actually, you know, that's not right what you've heard. This is what we've heard at school. This is what we've picked up from the mosque. And getting those messages out via people that were trusted within that family certainly were. But yeah, I'm still cognizant of the fact there are still a number there that are not being vaccinated. We've still got to continue with working towards them and getting that message out there. But I think the key here is that if you understand and listen to what the communities are telling you, you can produce material that counteracts that and gives a different narrative.
Thanks, Nadine. Lisa, did you want to add on that one, or she's trying to come in?
No, I was just trying to invite Nadine and Pam to respond.
Oh, okay. Pam, anything to add?
All I was going to say was that when we've looked at the vaccine data for vaccine 1 and 2, it's been pretty high in the South Asian populations. It's only really dropped. I mean, we only looked at this data about a month and a half ago, and it's really dropped for the booster vaccine. So there's still lots of work to do there, and we'll still continue to do that. But yeah, I hear what everybody's saying.
Thank you, Pam. Josh.
Yeah, I absolutely recognise what Nadine says about there's some people that just won't take it in every community, and I can reference several in Hebden Bridge who are the same. And I think, you know, that's a kind of universal thing. I think one of the things that I think we need to be kind of a bit on it with is thinking about the South Asian community and some of the kind of risk factors that were outlaid at the start in terms of the informal work and you know, the kind of cost of self-isolating. Sometimes the cost of having the vaccine and having a day feeling pretty rough and having to maybe not work that day might also come up. So I think particularly when we're talking about the third dose, so when there's no longer a requirement to have it in order to kind of go about your business and people sort of think, oh, well, I've got 2 doses already. I do wonder what can be done, A, to encourage uptake on that third dose, but also just to make it easier. And I think this is, you know, kind of all the behavioural insight work that you look at kind of from the government communications unit is that the easier you make it to do the choice that people know is probably the right choice, the better. So like we saw early in the pandemic when we had people at mosques doing vaccination clinics and so forth, I'm just wondering what kind of active outreach are we doing just so that people that are in kind of slightly less secure work and work that's kind of self-employed, what we're doing to make sure that we're supporting them to make it as easy as possible for them to make the decision that's right for them in the community.
Thanks, Josh. Shall I bring Sarah in as well, and then come back to Lisa on that one? Yeah.
Thank you. Yeah, I was just wondering what the uptake of sort of vaccines in young people, children, young people from our BAME communities is like, if we've got data on that, or if there's any sort of just any thoughts on that and how that's going, and also sort of thinking, I suppose, about well, just the educational inequalities that you know, may have been widened, and the sort of support around that, which I guess isn't really health and well-being, but it does have an impact.
Thanks. Lisa, do you want to come back on those two?
Yeah, just on the, I'll ask Pam if she could respond on the first point, but on the latter point around children. We as CHFT, as a community, and we are the provider for vaccinations in schools. I haven't seen the data yet, but that's something I can certainly look at and feedback. Pam, could you respond on the first point, please?
Yes, so just to make members aware that we're still going to continue doing those vaccine pop-ups like we've done at the mosques, and we've done a number of them at industrial sites, and just generally around Calderdale. So that's not going to stop just because we think COVID's ended, also the government's telling us.
Thanks, Pam. Okay, I'm not seeing any more, so can I echo the thanks to Lisa, Nadeem and Pam for that, particularly Nadeem for coming along and joining us, and we'll share the link to the video if we can as well, because it was excellent, and we're happy to receive that and endorse the recommendations. Thank you, everybody. So item 7, Calderdale Cares Partnership Agreement, and this will be is Rachel, yes.
Excellent, thank you, Chair. Good morning, everybody. So you'll remember back in October, I came to present to the board to provide you with an update around the work we were doing to establish the Calderdale Cares Partnership, so the health and care partnership for Calderdale as part of implementing the February 2021 health and care paper. So this is a continuation of that work, and today I wanted to talk to you about a partnership agreement that we have been developing across those different health and care partners, and it's very much something that we've built together to essentially set out, as part of working in partnership, how different partners, how different organisations across the sector are going to work together to make sure that we deliver the best outcomes that we can for Calderdale's population. A lot of this is very much about formalising things that have already been happening, because there are clearly some really great examples of collaboration in Calderdale, really great relationships already. So some of this is very much just about getting that written down and getting that commitment to working in that way together. It's very much aligned with the Vision 2024 and also the ways of working set out in the refreshed health and wellbeing strategy as well. So keeping sure that we're aligned across different parts of the system in that respect, and with the work of this board in particular. So we developed the agreement across the signatory partners that are reflected on the front sheet, and that took place over a period of August up until the end of December. Across January and February, that agreement has now been formally approved by all partners, formal boards, cabinet and governing body, and we wanted to bring it here as sort of a final stage of approval. You'll see in section 9 of the agreement that talks about the high level governance model for the partnership, and we have referenced the Health and Wellbeing Board. Absolutely see that as a really, really key part of Calderdale's infrastructure, providing a really important role in terms of setting that health and wellbeing strategy and supporting a really high element of accountability within our system. We know that the Calderdale Cares Partnership Board has to be formally accountable to the West Yorkshire Integrated Care Board, as it is a formal committee of that board. But locally, we're really keen that the partnership is locally accountable to this group as our sort of widest partnership board within Calderdale, another place for public accountability and also that important democratic accountability as well. So we wanted to bring the agreement to the board today to sort of seek that support in introducing the partnership agreement within the system. If approved, we will make it into a final first version and get that formally signed off, ready to implement at the start of April. It will be something that keeps developing as the partnership itself develops as well, to make sure it's still reflective and also to ensure that it remains fit for purpose. So there will be a bit of testing to do on that front. There will be updates to make at later versions, but this is very much about, again, continuing that journey, keeping this as a step within that process. So I'll leave it there as just sort of a brief overview and see if anyone's got any comments or questions.
Thank you very much, Rachel, and thank you for the work that's gone into getting us to this point. Are there any questions or comments on Rachel's report, or any points people want to make? As we say, it's been through a number of other bodies already. So in that case, are we happy to... Oh, sorry, Stephen, yes.
Yeah, it's just a minor point. Just really, Rachel, whether you're aware of the similar arrangements across the other places within the ICS, within West Yorkshire, and whether our agreement reflects the others, whether it synchronises with them.
Yeah, thanks, Stephen. So yeah, the other 4 places in West Yorkshire are also doing similar agreements. So Bradford has had a similar agreement in place for a number of years now. I think all the other places, including Calderdale, are developing something new. We have had discussions across the West Yorkshire footprint about the degree of consistency to be introduced across the agreements, given that we're all working in one system. So there are some small bits of the agreement that are consistent across all 5, but we're also really clear that whilst there will be shared work across West Yorkshire, there also still needs to remain that that focus on place, and it needs to be something that's really workable for each individual place as well. So they do look a bit different. They've got different levels of detail, and so part of the work we've gone through is around ensuring that this feels the right sort of level of detail and content for Calderdale, and that's very much been reflected in the feedback that we've had from partners.
Thank you. Any more, Mike? Yeah.
Thank you, Chair. Just to say that these arrangements will make some necessary changes to the Health and Wellbeing Board itself in terms of membership and in terms of reference. And Rachel, myself, and others and Ian are working on how you can have a discussion about that, probably at an informal session in the near future.
I lost my microphone. Yeah, thanks, Mike. I was going to make the same point, so that's something to come. Yes. Okay, so with those points, we're happy to agree those. Thank you, everybody. That's approved. Thank you. Excuse me. Item 8 is the Suicide Prevention Strategic Action Plan. I'm sorry, I've mislaid my note about who's presenting this one, so
I'll... good morning, everyone. Shall I just come in there, Chair?
Yes, of course. Yes. Sorry, Eugenia. Yeah.
It's Eugenia Cronin. I'm a consultant in public health, working with Debs Harkins, and I think you had Debs down to present this item. It will actually be me. I can't seem to get my video to work. It says that it's unable to detect the camera, so I'm really sorry about that. So I think Fazana has the slides, so you perhaps don't need to see me, but anyway, it's very nice to meet you all, and thank you for inviting us to present this to you. So my name's Eugenia Cronin. I'm a consultant in public health, working with Calderdale. I started in February, so this is, and I think this is my 6th day. I'm picking up this agenda from a consultant colleague by the name of Sue Forster, who I think some of you may well have met. I can't claim credit for all the really excellent work that Sue has done on this. And equally, I may not know all of the detail. So if there's something that I don't know today, I'm very happy to come back and answer after the meeting. So the plan is I'll be leading on the strategy until the summer. And I know that Debs Harkins is keen to recruit to this post around public mental health because of its priority in terms of public health and in terms of the council. Finally, just on this first slide, the content of this presentation is quite high level. You do have more information in your PDF documents, I think. So you've got the strategy, the strategy document and the action plan. So I hope that's okay. And I hope people have had a chance to have a look at that. So could we go to the next slide, please? Okay, the vision for Calderdale is to be a place where suicides are eliminated and where people do not consider suicide a solution to the difficulties they face. Excuse me. Also a place that supports people at a time of personal crisis and builds individual and community resilience for improved lives. Next slide, please. So a little bit of context, first of all. There is preventing suicide is a national priority, as I'm sure people around the table will be aware. There has been a national suicide prevention strategy since 2012, and more recently a health select committee published in 2017 with a cross-government work plan which came as a result of that, and a new Minister for Suicide Prevention was announced the following year. On the NHS side, the 5-year forward view for mental health does include targets around suicide reductions, and the NHS long-term plan from 2 years ago establishes suicide prevention as a priority and commits funding through integrated care systems. Local authorities are required to have a suicide prevention plan, and support has been provided by Public Health England, and whichever bit of the new system will pick that up. And this is essentially the suicide prevention plan for Calderdale is what I'm presenting to you today. Although I think even if there hadn't been a requirement to do it, I think Calderdale would have done it. Next slide, please. So a bit more context. The reasons people take their own lives are very varied and they are very complex. There's rarely one cause, and it can be the result of a number of interplaying factors that impact on an individual over time. These can be things like environmental stresses, alcohol problems, mental health disorders, and genetic factors. And I've just listed some of the environmental stresses there, such as being out of work, having financial difficulties, a loss of a significant other. And as I said, often there are factors that are multifactorial. Now, there was some accepted wisdom that for every suicide, about 6 people were affected, and this has been debunked. Some new research suggests that actually the number is more like 135. We know that those bereaved by suicide have a greater suicide risk themselves. Recent research on those bereaved by suicide showed that 8% had attempted to take their own life, 8% had self-harmed, 38% had considered suicide, and a fifth had engaged in high-risk behaviours. Suicides are the leading cause of death for men under the age of 50, and 75% of deaths are in men, and that's a consistent trend. And for every life lost in terms of the economy, the cost is around 1.6 million. Next slide, please. Now, just before I go into some statistics, it's really important to just point out that the graphs and figures that we use to describe suicides, they're not dry data. They represent real lives lost, real families devastated. And I'm sure people around the table will agree that no suicide rate, whether high or low, whether it's rising or falling, is acceptable. So let's have a look at some of these figures. Suicide rates over time, this is ONS data for England and Wales. So it's very reliable data because it's a big database, and that's over an almost 20-year period. And you can see that it shows a steady decline since 1981, with a few points at which there are rises. Suicide is more common in men than women, and you can see that in terms of the different coloured lines there. There was an increase in around 2015 nationally, and I will touch on that in a moment. Next slide, please. So rates in Calderdale. You'll see that some of these statistics refer to 2-year periods, so they use 2-year rolling averages. And you can see that the 18 to 20 rate, which is the most recent we have, was 15.6 deaths per 100,000. You'll also see that we use something called age standardised rates, which allows us to do comparisons, and it's a statistical method. So the rate in Calderdale was statistically significantly higher than the England rate, which you can see there, but it wasn't statistically significantly higher than the West Yorkshire and Yorkshire and the Humber rate. Next slide, please. And then just looking at Calderdale rates compared with England. So the suicide rate in Calderdale has increased over the last decade. The most recent data indicates that rates in Calderdale are higher than those observed some years ago. So between 2006 and 8 and 2007 and 9, those rates were statistically significantly lower than what we have the most recent rates. Now in England, I said I'd mention this, England has also seen an increase in the rate of suicide between 2015 to 17 and 2018 to 20. And you can see that just really slightly in that blue line there. It's a very slight increase visually because the database will be huge and therefore a small increase will be statistically significant. Next slide, please. So looking regionally, so this map actually includes English regions and Wales, and you can see that again this age standardised deaths per 100,000. There are really marked differences, with the highest rates being in the northeast, Yorkshire and the Humber being the second highest rate there, and right down to London being the lowest. So again, that's very good data. That's from the Office of National Statistics. And that's deaths registered in 2020. The next slide, please. You may be thinking, I mean, there was a lot in the press about speculation about mental health and suicides during various periods of lockdown, particularly during the pandemic. There was concern that suicide would increase. Now, and in fact, the National Centre, the NCISH, the National Confidential Inquiry into Suicide and Safety and Mental Health, which sits with the University of Manchester, has done quite a bit of work to have a look at this. So they set up some new data collection in England across a 9 million population. And the point made by Lewis Appleby in the BMJ was that the coroner system wasn't able to allow close monitoring because of the delays, which they quote as being 166 days between death and inquest. So they set up, so the National Confidential Inquiry set up a specific way of doing this. And what they concluded, having looked at those two periods, a pre-lockdown period and a post-lockdown period, was that there was no evidence of the large national rise in suicide post-lockdown that many had feared. There are some caveats around that. These are early figures that could change over time. There could have been higher rates in some local areas, and it was too soon to examine actually the full-term impact of a wider economic adversity on mental health and on suicide. Next slide, please. I wanted to show you this really helpful resource from Public Health England, which is around local practice. It's a local practice resource. And it just helps to shape really what I'm about to say about the Calderdale strategy. So suicides take a high toll. There are specific groups of people at higher risk. So 75% of deaths by suicides are by men. The highest rate in England is among men aged 45 to 49. It follows a very strong socioeconomic gradient. That's the jargon we would use in public health. So that means that people in the lowest socioeconomic group, being in the most deprived areas, are 10 times more at risk than those in the highest economic group living in the most affluent areas. The strongest predictor of suicide is previous episodes of self-harm. Preventing suicide is achievable, and suicide is everyone's business. A whole system approach is really needed. That's one of the reasons I'm talking to you today. Restricting access to the means for suicide works. Supporting people bereaved by suicide is an important component. Responsible media reporting is critical. And the social and economic cost of suicide is substantial and adds to the value for suicide prevention work, because it's not the only reason why you would do it. Local suicide prevention strategies must be informed by evidence. And in fact, this toolkit from Public Health England certainly was informed by good evidence. Next slide, please. So now moving on to the Calderdale approach. One of the key planks of this is that the issue is highlighted at the highest level. Again, hence why I'm here to speak to you today. There is a suicide prevention group set up, which will oversee the delivery of the actions via task groups under that particular group. There'll be regular reporting and exception reporting with a final report in 2024. And we will be using learning from both national and regional work to ensure we're drawing on the best evidence, the best practice. I understand the strategy has been to health scrutiny, and comments from that meeting have been addressed. And the strategy has, of course, been signed off by the Calderdale Suicide Prevention Group, and that was last November. Next slide, please. So the key elements of the Folderdale Suicide Prevention Strategy are these 7. So I've taken leadership and governance slightly out because it really crosses everything. And then there are 6 other planks. So to reduce access to the means of suicide, to reduce the risk in high-risk groups, to tailor approaches to improve mental health in specific groups, to provide better information, and I would add support actually, for those bereaved by suicide, comms, communications and engagement, and supporting research, data collection and monitoring. And as I said, actions appear under each of those elements in the action plan that you have. Next slide, please. So this slide just shows really the governance routes that Sue Forster put into place. So you can see that the Calderdale Suicide Prevention Group, which I will describe in a moment, is linked up to the Health and Wellbeing Board, and obviously has a connection into each of those 4 sub-parts of that board. We're also having to the 2, and we have a link into the Suicide Prevention Network at West Yorkshire and Harrogate. And then you can see the 6 elements which I put in the previous diagram. Brilliant. Next slide, please. So I said I'd mention the Calderdale Suicide Prevention Group, and I have noticed, just quickly, I have noticed a couple of questions and comments in the chat, and if you're happy with this, I'll pick them up in a couple of minutes. Right, so the Suicide Prevention Group has membership, you can see there. I'm not going to read that out to you. The purpose of it is to implement the suicide prevention strategy, an action plan, and report to relevant groups on activities and progress on reducing the rate of suicide and associated risks, with the ultimate aim of preventing deaths by suicide. And as I said, you can see detailed actions of that group in the actions I've circulated. Now, Calderdale works closely with our suicide prevention, West Yorkshire and Harrogate health and care partners, and this is just a screenshot from a really good set of resources. So you can see there that if you're looking for help, you can click on where you live and be taken to a range of organisations. So that's a really good resource there. The next slide, please. And I mentioned the higher risk and for people who've been bereaved by suicide and the need to support them. And this is a suicide bereavement service that is run out of, I think it's Leeds Mind. And it offers a number of different ways of supporting those individuals. And there's a phone number and email address that you can see there. Next slide, please. So this is really, I think this is my last slide. So why am I here today? Well, I'm asking you on the Health and Wellbeing Board to agree to the strategy. There are members around the table who come from different partner organisations, so please share with those organisations. Health and Wellbeing Board, please be ready to receive 6 monthly updates on how we're doing. And as a board and as a group of individuals, I would ask you to promote the importance of suicide prevention and keep the issue highlighted at the highest level. So I'm going to finish there. Thank you very much for your time, and I'm happy to try and answer your questions.
Okay, thank you very much, Eugenia. Ashley, you put a couple of questions in the chat. Do you want to follow up on those?
Struggling, yes, got it. Yeah, really what I've said there is that it's the levels in Calderdale are alarmingly high compared nationally and even regionally, although the suggestion is it's not statistically significant. I suppose my question is, why do we know why it's particularly high in Calderdale, and what actions we could or should be taking? I suppose they are centred on the presentation we've just been given, but I suppose it's just my shock and the numbers in Calderdale, and clearly the need to try and do something to help very much, which is, I guess, this is the beginning of it. The other issue is, or point I wanted to emphasise, was that if you look at the RAG ratings in the report, of the, I think there are about 16 issues highlighted there, only 3 of them have a green rating at this stage. I guess that's because we've only just begun this process. Is that correct? So there's 2 questions really. Why so high in Calderdale, and the relative success or not, is that related to the fact this is a relatively new report? Thank you.
Thanks, Eugene.
Yeah, very, very happy to address those. So the first question, yes, the rates are high. They're not statistically significantly different to statistical neighbours and geographical neighbours, but they are high. And the reasons for that, as I said, the reasons people take their own lives are multifactorial, and they will be a range of quite upstream factors, some of which a local authority such as Calderdale will not have within their gift to influence as much as others. So there are a range of structural factors in our societies and in our economies that will place different local areas and different populations at greater risk. I'm reminded of the Dahlgren and Whitehead rainbow diagram that you people will all very much be aware of, because it's such a central diagram. I wish I could pop it up on the screen, but you'll know it. And really, you know, it's those very outer parts of the diagram which are the prevailing social, economic and environmental factors, some of which the local authority will have a way to influence, and some won't be. Like, you know, it will be less within the gift. So I think the action plan is very much focusing on those things which we can influence, really, is what I would say. In terms of where we're at with the action plan, yes, you're absolutely right. There are only a handful that are green rated at the moment. But the action plan is new, so I was quite pleased to see that many, and hopefully over the next few months, with the work that we're putting into this through public health and through our partners, both within the organisation and outside, we'll be making some major inroads into those. But thank you for the questions.
Thank you. Julie, can I come to you next?
Thanks very much, Councillor Swift. Yeah, people will have seen I'm dropping in some resources into the chat from our Open Minds website, and Dr. Caroline Taylor is obviously on the call as well, who chairs the Open Minds Partnership, because we have done a lot of work around suicide prevention, and particularly in schools. And I've just dropped in some resources there that are available for young people. And our website is actually, I know not everybody uses websites, but it's actually really good for professionals who need advice and help, as well as parents. And I've just dropped in there as well a link through to something that we do have on the website, which is if a young person is feeling suicidal, where they can get help from 9 in the morning till midnight every day. You know, there's a kind of Samaritans-like call for help there that young people can use. So I just wanted to drop those resources in and just and share that with the Health and Wellbeing Board members. I don't know if there's anything that Dr. Caroline Taylor wants to add from the work of the Open Minds Partnership around this with schools, because I know we've done significant work with a couple of our high schools over the past few months.
Thanks, Julie. Yeah, can I jump to Caroline next then?
Thanks, Julie.
you beat me to the website. I was struggling to get the link quickly. But yeah, I think it would be safe to say that, or it would be fair to say that as an Open Minds partnership, which is literally everybody who is remotely involved with children and young people's emotional health and well-being is part of the partnership, that we do work very constructively and collaboratively together, including on the urgent needs. So I think there's a good start. We've never done enough, but there's a very good start in Calderdale from the children and young people's perspective, at least. So yeah, thank you.
Thank you. Can I go to Sarah, Councillor Courtney next?
Hi, thank you. Thanks for that presentation. That was really good report. Thank you. One of the things I suppose that I'm interested in is the fact that there's this really long gap of how long between or how long it takes for the inquest and to get an official diagnosis. But I'm presuming though that immediate, like that would be no good in terms of treating. If we're looking at, if one of the risks of other people of people committing suicide is knowing other people that have who have taken their life by suicide. So if so presumably, like people on the ground, whether it's services or the police or medical services, or sort of mental health support services, how does that work then in terms of being able to make a sort of identify that somebody has taken their own life, with and then being able to support the communities around them, and without having to have had that official sort of inquest label. I'm sort of struggling slightly for the words here, but I think you probably get a sense of what I'm trying to say. So is that the police or the services around able to pick up the fact that a suicide has occurred, so that then support can be put in without having to wait for an official sort of inquest?
And Caroline's responded to that in the chat. I don't know if you want to expand on that, Caroline.
Just to say that you're absolutely right. It's been a ridiculous challenge over the years. The information we get is so late that it's impossible to put in any proactive help and make any plans or changes to things in a timely fashion. But one thing we do have in Calderdale is good relationships across all our partner organisations. So if there are incidents that are suspected could be suicides, we do have channels of communication open so that the relevant organisations get to at least find out that something's happening, and so we can take some appropriate action. But it's not ideal in any way, shape or form, but it's not for a lack of us pushing to get a change in things.
I'll just come back on that very, very quickly, Tim, if that's okay. Yeah, so I suppose in doing things like being able to identify any sort of clusters or sort of groupings where presumably that's also then a really massive challenge, isn't it, to be able to identify those and again go in with sort of preventative or helpful services. So and is this something that's sort of being looked at by the coroners and the like, to try and reduce these timescales down?
So I could come back on that to say yes, but certainly not quickly enough. But we know that we have pretty good systems in place. So when there was a recent concern that there might be a cluster that was developing, we within hours, and if not days, the sort of senior leaders involved had all had discussions to see what we could do to support where that might be happening, even though we didn't at that point know whether it was going to represent a cluster or not. So we do have good relationships and good partnerships, which I think are facilitating those sorts of conversations. But like I say, it's kind of done in a not official through the coroner way, because that process is just inherently going to always be too slow.
Thanks. Eugenia, do you want to add something on the work on that?
Yes, absolutely. And thanks very much for the question, Councillor Courtney, because this is absolutely key. You point to a really important challenge there, and we are, to reassure the board, we are actively working on this. The bereavement, the suicide bereavement support service, for example, met with myself and colleagues earlier this week to talk about how we can move that forward and how we can address those issues. And as Councillor Courtney says, we need to be able to act where there's a suicide suspected, and that is certainly what we're using as our aim. So we are working on that, and I think, as Caroline Taylor has said, that there are very strong partnerships. I mean, I'm new to this, but I'm already seeing that's very much there. So I think the door is open.
Thank you.
Thank you.
Neil?
Yeah, thank you, Chair. Thank you for bringing the strategy today. I think it's been really helpful and useful conversation. I'm a bit confused with one of the comments in there about people not known as services, because I think one of the key statistics I've seen in Calderdale and across West Yorkshire is the huge amount of people that are known to mental health services. And I do wonder whether the action plan, particularly around the suicide prevention thing, is strong enough about actions. There's a lot of raising awareness, but if a lot of these people are known cohorts, surely it's about having our package of care right to be able to support them, not raise awareness to people that come into contact with them. So I do wonder whether that bit needs beefing up, considering people that are in mental health and community services, about how people could be more proactive to help manage people's mental health before getting to the sort of the warning signs and into the sort of the crisis management at the end. It's about being a bit more proactive upstream so that we're not at the crisis stage. Because I think the actions are a bit great about raising awareness, but I'm not really sure what actually that's doing to actually help people that will be in services already and actually help prevent things.
Thanks, Neil. Eugenia, do you want to come back on that?
Yeah, sure. Again, a really, really great point, and I'd like to take that feedback and see what we can do about strengthening that. So thank you. It is. I've seen some recent evidence about the number of times that people have been in touch with various services as well before taking their own lives. So there's something about being known to some people who take their own lives won't have been known to services. Some will be known to services, and some may not have been in touch with those services recently. So it's quite complex, but I would, if I could take that as a point of feedback and see if we can strengthen that with NHS colleagues.
Thanks, Eugenia. Yeah, I got that same confusion that I've heard it said that on the one hand they claim that most people are not in contact with services, but it's a presentation for the launch of the West Yorkshire suicide strategy, which I was going to bring up and mention also about how the two connect. Again, the presentation on that suggested the opposite, and it might be about what people mean by in contact and being known to, but helpful to clarify. Stephen.
Thank you, Chair. Yeah, I was just going to make the same point as yourself, Tim, same wavelength about Tuesday's West Yorkshire Partnership Board and the suicide prevention strategy that was launched, and action plan 2022 to 2027. So obviously we need to align with that and be aware of what's in it in terms of the action plan. Certainly, it's one of the 10 big ambitions for the integrated care system in West Yorkshire, and there's a target to reduce suicide by 10% in that 5 years. I don't think that goes anywhere near far enough. So I think that we should be a large contributor to that 10% reduction and actually aim to overstep that even in the shorter term. So if we can really see and identify what is the evidence-based approach to reducing suicide, and see how we can maximize resource input into this, if it's the largest cause of death in under 50-year-olds, then we need to do something. We need to do something about it, and it's got to be adequately resourced.
Yeah, thank you, Stephen. Caroline, you want to come back in?
Sorry, yeah, just on that point about the whether people are actively in service users at the time of suicide. So there is a good proportion of people who will have had contact with services at some time, but as Eugenia said, it's the fact that they're not in contact with services at that time, which makes it very difficult to intervene. And I absolutely agree with you, Neil, that to strengthen the specific actions would be really, really positive. But the challenge really is that most of these people aren't actually tipping up at their GP surgery or their mental health services or wherever in the time leading up to their suicide. So that's what it's about, raising general awareness, because hopefully they're in contact with somebody somewhere, whether it's their barber or the local shopkeeper or whoever it is, and that's where the general raising of suicide awareness is so key, so that all of us, and when it says all of us in the action plan, and the things that we can do, it really does mean everybody who lives in Calderdale, not just professionals. So it's a big and complex challenge, but I think it's would be really good to strengthen the actions.
Thank you, Caroline. Okay, not seeing anybody else indicating. Eugenia, is there anything else you want to sum up on?
Well, just to say really, I think the questions and the comments have been enormously helpful, so thank you for that. We'll certainly make sure that we're aligned with the West Yorkshire overall approach. And I just really wanted to end on the point that Caroline has just made. I think that is so important. It is everyone's business. It's not just the business of some services. So it is about gearing up the whole system, the public sector, the voluntary sector, communities to work on this. And that, I guess that is why there is such a strong flavour of raising awareness. So that is important. That could completely take the point about beefing up other areas of the strategy. Thank you.
Thank you. And yeah, just to endorse the West Yorkshire strategy, I mean, firstly, has that very similar theme about it being everybody's business, but also, you know, it's very clear that it's there to add value to local strategies, not to replace them. So that's good. So thank you everybody for contributions to that. It's obviously an issue we all take extremely seriously, and I'm sure we're happy to agree the strategy and action plan with the comments that have been made there. I'm just seeing nods to that. Thank you very much. Okay.
Thank you.
Thank you, Eugenia. Item 9 is the COVID-19 impact assessment, which I think we had a look at an early version some time ago. And yeah, Sian, with your World Book Day, just to prove I've been following social media and know what's going on in the world, your World Book Day background. Over to you, Sian. We can't hear you.
Sorry, my mute. I'm so terrible. I would have thought I would have got better at this by now. But thank you for the invitation, and thank you, Chair. And hopefully people will recognise the lovely picture from Shirley Hughes, just celebrating World Book Day today. So my name's Sian Rogers. I'm Policy and Project Manager and lead for the voluntary and community sector for Calderdale Council. And I'm here along with Will Boys from our business intelligence team to give you a bit of a quick overview of the COVID impact assessment, which, as I understand that you have seen here before, and I know it's also been to various other meetings in the last few weeks, actually. So we don't want to kind of spend too much time repeating some of the things you might have heard elsewhere, but give people hopefully a bit of an opportunity to see what's in that impact assessment. So I was going to do a very quick introduction, and then I was going to open it for Will to just do a quick bit on the key messages that are at the beginning of the slide pack. I know you've had it in advance. There's a lot of data in there. I really appreciate there's an awful lot of data in there, and some of it crosses over with other key information that I know you will have in services and in partners. So this is what we wanted to do with this, is to really try and add value and provide a holistic view of the impact of COVID, alongside what you might have within your own services and within your own organisations. So, Will's going to just pick up a few of the key messages, but then what we wanted to do was, if people had had some opportunity to look at the data, we to maybe give you the opportunity to ask any specific questions about particular areas, and we will do our best between us to answer those. But if you don't, then we thought Will was prepared, I think, to kind of highlight a couple of key areas that we thought you would find useful. So I think Will's got the ability to share his screen, because I think he's got the slide deck that you've been circulated. So is that right, Will? You should be able to.
Yes, I think I have. Just bear with me. I'll get that set up and share it. Okay. Okay. Hopefully people can see that now.
Yeah. Do you want to go the slide before? Will, just the introductory one.
Okay.
Yeah. We'll look at the picture of Halifax, but then yes. So just as a brief introduction, I think you have seen this at the Health and Wellbeing Board previously, but we started to do this impact assessment right back early on in 2020. Myself and the business intelligence team in the council were tasked with trying to start to pull together in a holistic way data locally in Calderdale, which helped us understand the impact of COVID, not just on health and the specifics here in terms of the specific data and the impact on people in terms of COVID, people testing positive with COVID or becoming poorly with COVID and deaths, but to look at some of the other things that were being impacted across health and wellbeing in a much more general sense. So that the way we've set it out is very much around the 3 council priorities, which I think you'll all be really familiar with, around reducing inequalities and tackling deprivation, sustainable towns, and that broader economy, how the impact on the economy, and also looking at how that may have an impact on our priority of tackling climate emergency. We've really tried to look at some of the things that are emerging nationally and say, does this tally, are we able to demonstrate this or evidence this through local data? And sometimes that's very hard. I know many of you will be aware of the challenges with trying to find local data, and also the kind of data lag for a lot of the long-term things that may well be being impacted by COVID. We thought this was a really important document and piece of work to do, because we want to use it alongside the other insights and intelligence that we know we're all gathering. There was some discussion earlier on about the impact on the BME community, obviously across mental health and wellbeing, lots and lots of data, but to really use this to look at that long-term impact on wider outcomes and the data, so that we can use that to inform our recovery plans going forward. I think many of you will be aware that we have set up an inclusive economic recovery board during COVID. So that board has been established to really think about the impact on the economy and how we tackle that. And when we published our inclusive economic recovery plan, we also published the first iteration of this piece of work, which was back in March 2021. This is now obviously updated into February 2022, and it gives us a good sense, I think, of those things which have continued to change and what has now changed in the 2 years that we've had since COVID, since the first lockdown. So it's kind of taking away some of the things which we thought might change. A good example of that is the need for food support, which saw a massive spike early on in COVID because of the need to provide food support for people who were self-isolating, and it created a huge amount of demand and a lot of concern, and it's certainly in the voluntary and community sector, but also in the council and other partners, about how do we respond to that demand and support those people. But that has now seen quite a considerable drop down off into kind of similar levels to pre-COVID, but it's definitely still higher, which is showing the impact of some of the other wider impacts, so stuff like the cost of living crisis and so on. So I think that's probably enough for me in terms of an introduction. What I did want to kind of just leave you to think about in terms of some questions, we had a really good discussion about the impact assessment at CLT, our council leadership team, last week, about how we hopefully can use this document. I think we probably, we're not thinking that we'll do this again, but how we use this document to identify key measures across the whole of the place, if you like, health and wellbeing, that we do need to continue to track over time going forward, and use those to inform all of our recovery works and strategies going forward, and making sure that we are joining up the dots between the health and wellbeing strategy, the inclusive economy strategy going forward, and making sure that we're all aware of some of the kind of long-term impact of COVID and beyond. So that might open up some questions and some thoughts after Will's had a quick whistle through the key messages. So I'll hand over to Will.
Okay, thank you, Sharon. So I was going to run through the key messages from this version of the impact assessment. So as Sharon mentioned, it's predominantly structured around the council's 3 priorities, but it does include an update on the pandemic and the immediate impact of infections and hospitalisations. So at the point that this was updated in January, we were seeing obviously significantly high infection rates locally as a result of the Omicron variant, and that had resulted in high levels of hospitalisation and also high rate of infections in local care homes. We also did see an increase in deaths after this was updated, but obviously not in line with previous waves. So moving on to the first priority, reducing inequalities and the causes of deprivation. The information that we've been able to find so far has suggested that there will be an impact on levels of physical activity and obesity locally, and that's likely to mostly affect people from BME communities and those with disabilities or long-term health problems. Since this was updated, we've noted the information from the health needs assessment that was undertaken with schools last year, which shows decreased levels of physical activity amongst children. So that's obviously kind of corresponding with our early findings on that. Picking up on mental health again, we kind of noticed that this was likely to be an area affected in the early versions of this, and data that's come out subsequently has kind of backed that up. We know that there's been an increase in referrals and requests for mental health assessments to the council, and also to NHS data, which is also showing increased contacts with children and young people locally. And again, the health needs assessment undertaken with survey undertaken recently also shows kind of issues in relation to emotional well-being for Calderdale school pupils. As Sean's already mentioned, the impact assessment highlights significant increases in activity related to food banks. What it also shows increased demand for free school meals within Calderdale during the pandemic. There's a range of information on kind of housing related indicators in the document, and that shows an increase in repossessions locally since the eviction ban was lifted. But however, that does still remain below pre-pandemic levels. What we have also seen though is an increase in temporary accommodation, which mainly relates to single males, but there is an increase in relation to families and families with children. At this stage, it's still unclear from a kind of statistical perspective to determine the impact of the pandemic on educational attainment. We haven't had a kind of stable period in terms of those statistical releases in the last 2 years. But what we do expect is that there will be an impact on those from the most disadvantaged backgrounds in terms of educational attainment. One particular issue that we would like to highlight is the impact on the childcare sector. So the move to the initial impact of lockdowns and the move to increase home working has had a real impact on that sector, with some particular providers particularly affected, and a net loss in childcare places to the borough. Moving on to community safety related measures, the main point on this is that we saw a significant reduction in certain crime types during 2020. Since then, we've seen things returning to pre-pandemic levels. In particular, this year we've seen a 35% increase in hate crimes. We did see an initial incredible response from the community and voluntary sector in response to the kind of first waves of the pandemic. We do know that sector will be negatively affected by the initial lockdowns and the ongoing impacts of the pandemic. So moving on to developing sustainable towns. One thing we are able to evidence in this version is that the the number of benefit claimants in the borough has come down. So that was a positive to take from this. But we do still note that young people are disproportionately affected. So they haven't seen the same decrease as the overall rate of unemployment benefit claimants. Another point to make in relation to benefit claimants, though, is that we haven't seen the same decrease in universal credit claimants overall. So we have seen some decreases in relation to those people who claim unemployment, universal credit, and who are not in employment, but we haven't seen that same decrease with people who are in employment. So that suggests that there are issues around low levels of income sustaining as a result of the pandemic. In particular, women are now the largest group, women in employment are now the largest group amongst universal credit claimants, to previously men. Moving on to apprenticeships, we have seen a decrease in the number of apprenticeship starts, particularly at the advanced level. And if we look at that by age group, it's the under 19s that have seen the largest reductions in apprenticeship starts. As might be expected over the duration of the pandemic, local businesses are reporting decreased turnover. In 2020, that was as high as 72%. 72% reported that business has been negatively impacted. A proxy indicator that we've included in relation to the economy is on property sales. That showed a significant reduction in property sales during the lockdown, but a bounce back to some extent last year before kind of falling away at the end of last calendar year. Footfall obviously is another good indicator of kind of economic activity and confidence, and that showed a significant recovery in late 2021, almost returning to just where we were before COVID. And finally, on this area, we did see an increase in business startups during 2020, but the overall number of active enterprises declined, so a net loss on that one. And finally, the measures linked to taking action on the climate emergency. The first and second lockdown saw a significant reduction in traffic overall, and obviously a significant reduction in kind of emissions and road traffic accidents. The data that we have access to shows that we've now kind of returned to previous levels, and anecdotal national data does suggest a shift to personal car use due to kind of reduced use of personal transport, so public transport. We include measures on recycling, so that it's kind of a byproduct of people being at home more and more online shopping. So that showed an increase in recycling during the first lockdown. But the flip side of that is that we also saw increased fly tipping in 2020, and that has continued to increase in 2021. Another kind of link to lockdowns and the shift to home working was that we saw a reduction in the council's use of energy, and subsequently a reduction in the council's CO2 emissions. At the point that this was updated, we were estimating that home energy bills will have risen by £32 a month as a result of being at home more, but obviously there are kind of bigger issues at stake, and that's likely to be significantly higher going into this year and next. And finally, we saw significant increases in the number of people cycling during 2020, but the data that we've got access to shows that that has now returned to pre-pandemic levels. So that's the summary. I'm happy to focus on any specific areas that people kind of would like further detail on.
Okay, thank you.
So much, Sean. Yeah, so I suppose, yeah, just kind of, we know that there's a lot of detail in here, but we felt that if you've had a chance to look through this in advance, if there were any particular areas you wanted us to focus in on, and we could talk, kind of go into those, or just general questions really, and also just thinking about how, I think that point about things that have changed significantly in those 2 years, where, you know, and are we able to use those usefully to act as a kind of spur for discussions about priorities of focus, for all of our recovery plans going forward, whether that's within organisations and that we can, obviously share this data for that to be used for that, or for the Health and Wellbeing Board and other partnerships.
Okay, thanks very much, Will and Sean, for that. Ashley, Councillor Evans.
Thank you, Chair, and thank you for the data. I mean, wow, what an incredible amount of data. I have to admit that I've not had a chance to look through it in detail, but I will certainly do so. In scanning through it, one bit sort of jumped out at me on slide 9, which is the reducing inequalities in relation to mental health. It just struck me that when we look at the mental health assessment referrals, there's a steady increase in terms of assessment referrals, whereas intriguingly, people in contact with mental health services seems to have declined. Is that just because it's more difficult in COVID to have that contact? Just interested to know why that might be the case, with one going up and the other one going down. It seems a bit sort of counterintuitive, I think is the expression. Be interested to hear your thoughts on that. Thank you.
Thanks. I don't know, Will, if you've got anything from the data on that. I might ask Tim Fox if he's any comments as well.
The only thing I will clarify is that it's from two different sources. So obviously the information on mental health assessment referrals is referrals to the council, whereas the other information is based on local NHS providers. So it's most likely to relate to SWIFT.
Thanks, Will. Tim, can you add anything on that one?
At the moment, I can't know, but what I can do is I can get that information to you.
Thanks. That'd be appreciated. As I say, it may partly be to do with different sources. Yeah. Okay, Julie. Yeah.
Thanks, Councillor Swift. Yeah, firstly, just to say thank you very much for the presentation and the detail. Yeah, I've seen this at the corporate leadership team, and it is an incredible, rich resource of actually what's happening across the whole system and the impact of COVID. So thank you very much for bringing it here today. Just a couple of things to pick up in respect of education. I'm not going to go into a lot of detail, Councillor Swift, because there is a full education recovery programme that we've worked up with schools and school leaders. Lots of work happening around catch-up and tuition, mental health support for teachers and for pupils, and access to IT, as you know, is a really big focus for us at the beginning of lockdown, to make sure that children had access to IT and the internet. But I just wanted to focus on the early years position, because this is an interesting one, I think, to keep an eye on. And Councillor Courtney and I had a briefing on the childcare sufficiency in the borough a couple of weeks ago from our early years and childcare team. And their role is to make sure there is sufficient early years provision, and there's also the quality of it is good enough for our children. And it's quite a change in pattern here, and it's already been mentioned in the presentation about working patterns with parents is changing, and childminders, for example, saw a huge drop off in requests, and people wanting childminding resources by about 50%. Now that's reduced to 20%. So you can see things are picking up with parents returning to work. Just to assure the Health and Wellbeing Board, we do have in nearly every area sufficient childcare places. That's not to say there isn't pressure within the early years system, because there is. And I think we're seeing in the early years sector, like we are in schools and other areas of work, like social work, people leaving the sector to work in catering, in hospitality, and actually leaving the kind of early years profession. So I think there's some pressure there in trying to recruit enough managers and enough staff to run that business. So I think it's one to keep a careful eye on, but to assure you for now, we do have sufficient places in the borough, and it's something that obviously myself and the lead member would be reviewing on a regular basis, along with the education recovery plan. Thanks very much, Councillor Swift.
Thank you. That's really helpful. I mean, there's so much in this, as Ashley said. It's such a rich report. It's actually quite hard to work out what else to pick up and take forward. But it is a tremendously useful piece of work. Sian, do you want to come back?
Yeah, I suppose from my sort of perspective, supporting the Inclusive Economy Board, it might be also helpful to say that we are really using this to focus around the economic data and looking at both the skills agenda, but also how we fill vacancies, looking at sector support for different sectors, working with the Chamber of Commerce and the Federation of Small Businesses to think about what the specific challenges for both businesses, but also the skills gaps and supporting people furthest for employment have to kind of match the people we have and that we need to support into work with the businesses and the gaps and vacancies that we have in the economy. So that's a real focus for us at the moment, and this data is being used to kind of help give us that focus for the strategy going forward. So our most recent meeting of the Inclusive Economy Board, which was focused on skills, we had a really rich discussion about the challenges around the skills agenda, and we do know that we do need to focus on sort of upskilling and supporting people to upskill, particularly in some of our most deprived communities, but also thinking about how we have an issue, a challenge around the low skill levels being quite high relative to other boroughs in the region, and making sure that we're doing more to join up our skills system and our skills approach. So we're developing a skills framework across the sector. So we've got lots of very patchy, good but not joined up provision at the moment, I think, for adult learning and the college and all sorts of other providers. So that's something that we will be focusing on a lot. I think the other thing to say is in terms of businesses is how we've got a lot of good intelligence, anecdotally though, mainly about where the sector gaps are. And there is a challenge about future jobs. So a lot of the current gaps in the economy and vacancies are in areas where we might not be very future proof. So, you know, things like retail, there's lots of gaps and so on. But we need to be making sure that we're not just skilling up for those current vacancies, but also skilling up for the future. And we're having a lot of conversations about green skills, particularly, and how all jobs need to be green jobs, and what that means in terms of the skills strategy going forward. And I think that's really important for the Health and Wellbeing Board because of obviously the relationship between good jobs, good skills, opportunities for good work, and how that helps deliver the wider health outcomes and health well-being that we need to see in the borough. So I think that, you know, that might be something that you might want to reflect on in this board, is how we join up the two bits of work and link across with the economic work that we're doing and how that relates to the wider determinants of health.
Yes, I know we've said we're not doing this again as a COVID impact assessment, but that I know people, those who do the work wins, but this could always kind of transform into a sort of a state of Calderdale report, which we don't quite produce in that report. So it might be something we want to talk a bit further about. Sarah, Councillor Courtney.
Thank you. Thanks very much, Sian, for bringing this report, and Will. Really interesting, lots and lots in there. Just one thing that I'm sort of quite interested in, and we're talking about sufficiency, but sufficiency of housing and housing placements. And there was mentioned about that homelessness or people only in temporary accommodation is sort of increasing slightly. And I was listening on the news to some news report the other day about the situation in Cornwall, where there's sort of lack of social housing, and the number of houses that are now being used as holiday lets is about exactly the same as the number of people waiting. It was something like, I can't remember the number, but if say it was 5,000 families waiting for housing, and there were 5,000 holiday lets. Now, obviously, you know, in terms of sort of sustainability, we need places for tourists to come and stay. So it's about that balance, isn't there? And I was just wondering, is this sort of being considered, and is there anything that we can do about this in terms of making sure, you know, I mean, I've had conversations with Julie and Leslie about you know, small schools and some of the pressures on small schools where people aren't moving into some areas because there isn't affordable housing for family, which is affecting school places in some areas. It's a very uneven picture across the borough, obviously, because we've got, you know, the demographics of our different areas are very different. But I was just wondering how is that being looked at in terms of the sort of sufficiency of housing, and not even necessarily, I mean, ideally sort of affordable housing, but even just any housing really for families to be able to have in different areas across the borough.
Thanks, Sarah. Sean, you want to have a go at that one?
I can't answer the question, I'm afraid, Councillor Courtney, but I can say that there is obviously a housing strategy which has recently, I think it went to Cabinet a couple of months ago. I'm trying to think, I think it went just before Christmas. And I think, I mean, obviously affordable housing is within that, but I couldn't tell you the detail of the plan. I think that might be something that if you would like to know more about, I can take back to the team that I'm in. So just, my team in economy, housing, investment, where I'm based, includes housing, and Heidi Waters would, I almost certainly be able to give you a detailed response to that answer.
Okay, thank you. So I'm not seeing any more comments on that. So thank you. Oh, sorry, Stephen. Yes.
Yeah, I'm just looking at slide 6, 7, and 8. And slide 6 looks at levels of physical activity. And there's a sentence in there. A survey undertaken locally during the first lockdown suggested a massive disruption in adult physical activity behaviour. If sustained, this would have we predict to have a massive impact, not least on the BAME population. And actually, levels of physical activity have dropped significantly in the BAME population. You can see that I think that's on slide, is it 7 of 26? And there's been a resultant impact on weight, BMI as well, levels of obesity, not just seen on the next slide in children, but also anecdotally in adults as well. And control of diabetes, likewise, has really been impacted on very significantly. I just think these are very important areas for us to think about in terms of actions that might come out of this report. There are lots of services available through the Better Living service and digital weight management services, but I don't think we're utilising them, and I think we need to do a lot more. And then the resultant impact on mental health that reduced physical activity has. I don't know what these numbers particularly refer to, mental health assessments, but there's been a pandemic also of mental ill health, and yeah, I suppose related to all kinds of different factors, including loss and financial challenges and health impacts of COVID, etc. But again, these are two key areas I would have thought of: physical activity, diet linked into that, and mental health that we need to respond to as a system.
Thank you, Stephen. Yeah, certainly. Okay, so thank you. Yeah, thanks, Sean and Will, for that presentation. I think there's quite a lot in there people want to take away, and I think we'll look as we look at the agenda for future meetings. Just want to look at which parts of this might perhaps help to inform some of those discussions. Okay with everybody? Thank you. And obviously, if people have more detailed questions on it, Sean will try and pass you on to the people who have the answers. Yeah, rather than what Andy was saying, you'll answer them all, Sean. Okay.
Thank you very much, Chair.
Okay, thank you. Right, okay, so item 10, system pressures. Ian, this is down for an oral report from you.
Thank you, Councillor Swift, and I appreciate the time, so I won't go on too long. So we've established this oral conversation about system pressures throughout the pandemic, and clearly the last time that we met as a formal wellbeing board, we were definitely in the kind of peak of Omicron and some of the challenges that was creating in the system, both in terms of numbers of people who needed to be in hospital with COVID, but also our workforce across health and social care was challenged with Omicron as well. So there was a workforce resilience challenge, but also seeing higher numbers of people presenting into hospital. I think it's good to note that there are fewer people in hospital with COVID, and certainly in ICU, which is a good thing. I'm sure system partners will describe any particular issues for themselves, but I think we're operating at a good position. I noted on Tuesday we moved into what was technically the meteorological spring. But winter really does last in health and social care. The kind of real heat of the pressure of winter lasts until Easter. So I don't think we're out of the woods yet. But certainly in terms of COVID, we're seeing reducing numbers. But I think what we've got is a tired workforce, but also needing to move into recovery phase. So I think it's going to be a very challenging few months ahead. But as a system, I think we're working well together. At next week's Urgency and Emergency Care Board, we're shifting our focus, which has been very much focused in the last few months on the acute system pressures, to looking at mental health. And I think it resonates with some of the conversations, the themes, the conversations we've had as a Health and Wellbeing Board today, because we will be seeing people still impacted emotionally into the mental well-being from post-COVID as well. So I think it's, I think if we're talking about the normal way in which we evaluate the pressure in the system is done on an OPAL system that rates from 1 to 4. I think generally on average we're saying it's at 3, so we are coping, and hopefully things will stabilise further. If there are any questions or if any partners want to add anything from their perspective, please do.
Thanks very much, Ian. Yeah, any additions to that? Comments to that, or not seeing anybody? So can we simply note that at this point? Thank you for that update. Okay, so item 11. Well, it says items for information, but 11A on the Better Care Fund. Again, can I come to you, Ian, and just say, can you just confirm where we are with this and whether we have approval?
Yes, sorry, I didn't mean to forward to the section the formal approval from NHS England in terms of the Better Care Fund. So we got through the national assurance process. We are now formally compliant. So I'll make sure that that's added to the notes. But also, if partners on members of the board would like to see the overall summary of submission for the Better Care Fund, we can circulate that to members as well.
That's great, thank you. So note that if anybody wants to see it, please do ask. Okay, nothing on that. So the remaining item is the forward plan for the June meeting. Mike, do you want to say anything on this one?
I don't think so, Chair, no.
Okay, we haven't. Unusually, we've not identified any new items for the agenda today, which is unlike us. We usually do, but that's great. No doubt we'll add to it in the agenda setting and informal meetings. So unless anybody has any other business, I'll say thank you very much, everyone. Thank you to all our presenters this morning. Been some really